My name is Candice Ward. I lead the CDEP program, which is an online program, and I am your host for today. I get the boring housekeeping and then I'm going to hand over. So as I've said, if you're just joining, please say hi in the chat. But the questions do need to go into your Q&A. So there's a separate chat and a separate Q&A. Please put your questions in Q&A so we can answer them as we go along. If you happen to have any technical issues, you can't hear any sound, your camera, it's often best to leave and just rejoin. The webinar is being recorded and will be shared afterwards. So if you want to watch anything back, we will be providing a certificate of attendance for people who are attending, so that if there are a number of you all accessing the same link, please let us know that in the chat so that we can also send you a certificate of attendance. And yes, the slides will be shared with you as well. So certificate of attendance and slides will be given to you, and so you can really relax and enjoy the webinar. So welcome everyone. I am now going to hand over to the official host for the day. And I think actually Eleanor has disappeared. Eleanor is due to host us today, but I can't actually see her on the camera. Can anybody else see her on the camera? She seems to have had issues. So I'm just going to go on, and Eleanor will join us in due course. We have a very, very prestigious panel of people who are going to be talking to us around this topic about hybrid closed loop in pregnancy. They will all introduce themselves as they come to their section. We do have a full agenda and people will be keeping to time. So we will go through this quite promptly, and please do try hang on for the duration of the event. These are our disclaimers that we will be sharing again with the slide deck. So I would just like, these are the aims and objectives for the session today. So it is very exciting that by March 2024, the hope is that all pregnant women with type 1 diabetes will be offered hybrid closed loop. So we are going to go through sort of why hybrid closed loop is important for people who are pregnant, the evidence behind hybrid closed loop, and then especially for ICB leads around rollout, commissioning, and then also for diabetes, pregnancy healthcare professionals about onboarding. So it's really trying to cater all aspects of supporting women with type 1 manage pregnancy on a hybrid closed loop system. If Eleanor joins us, we will have more from her towards the end of the session. But I'm going to hand over to Partha to take us through the story so far. Partha.
Thank you very much, and thank you, everybody. So first of all, to start off with, if there's any queries beyond pregnancy, there is come to us separately. This session is very purely about pregnancy side of things. So I'm going to keep it very short so I can hand over to the main people concerned. I think what I would say is that this is probably one of the best examples of science into lives you will see throughout the course of healthcare. So it started off with the journey of the concept study, Helen, Eleanor, all part of it. And at that time, we worked together. That came out in 2017. And then after lots of discussions and negotiations, we managed to get CGM for everybody with pregnancy in 2019 in the NHS long-term plan. And some fantastic work from the team. Karen Kennedy is here as well, one of the leads in helping us deliver it. We do have widespread coverage, huge uptake, but most importantly, I think what it's shown is the impact it's had. So forget the science, forget the access, forget the numbers. The important thing is it shows that for the first time, we turned around the outcomes for mothers with type 1 diabetes, better outcomes for babies. And that is a fabulous example of success in the NHS, which always is looking for success. So that's a proper population change. But Helen and Eleanor clearly are people who don't rest at only having one success. So immediately they were on to another trial, this time about hybrid closed loops, and that was the ADAP trial. But because we have obviously worked quite well together, closely, and this time both of them were on our backs even quicker than last time. So literally, I think within weeks, if not a month of the ADAP trial coming out, we had a NICE following that up by saying this should be available not only for women pregnant, but also trying for pregnancy. And I think that's really important because it takes us to the next step. And whenever people say to me, what does it do? I think I'm the least qualified person to say it because I can't get pregnant. Neither will I go through what women go through in their pregnancy. Neither do I have type 1 diabetes, so I'll have absolutely zero idea what it is to prick my fingers, let alone do it 8, 9 times with all the other hassles of pregnancy concerned. So what we are doing is we have made it a priority group as a delivery point, and Verity in our team is one of the other members of the team, along with Karen. And you will listen to the other panelists as well, all of whom are incredibly engaged with this, and we will make it happen. So along with children, this is our priority group, and it's about changing lives. And this is not sort of flippant words. I think if we do manage to get it, and we're having an offline conversation about targets, weren't we, Karen, as to when we're going to deliver it. And, and those of you who are on the call and know me, my targets, it should be happening right now. So I'm going to sort of say that I'm going to ask that we try and get it done by middle of 26. I think we should be in a position that we offer everybody everything. NHS England are going to take a big gulp, but hey, listen, when did we ever listen to NHS England and their targets? We didn't do that with Libra. We're more going to do it with this. So I'm very grateful for everybody who's come around and wants to do this. And it's fascinating. It's fantastic. And I think I'll finish with also this by saying, it's also important sometimes to take context, take a deep breath, and take a step back and see where we are as a country. It's in the same NHS, which is struggling on many fronts, as you all very well know. New government, new hope as ever that comes around every 4 years for all of us. But in the context of all of that, we are about to provide women the best thing that science can provide beyond a cure for their type 1 diabetes when they're pregnant or trying for pregnant. That's fascinating. That's fantastic to be able to do so. And those of you who go to international conference will know this. We are pretty much the only country to be able to be in a position to do so. So we have some funding, we have some initiative, but most importantly, we have some fabulous people leading it, and we have got a lot of passion. So I have no doubt it will happen. People told us, didn't they, Helen, that CGM would take us decades to get it through. Didn't. Neither will this. So thank you very much for everybody coming along. The technicalities of how do you fund and how is it going to happen, and that will happen. That will all fall in place. But I'm pretty sure by 2026 we will have absolutely done it. Again, I'll finally finish by paying acknowledgements to everybody who's on the call from my team, but especially I think Helen Murphy and Eleanor Scott and Karen, I would say, for the work they've done with CGM. So this is chapter 2 for them. They're veterans at this now, so this should be the easier bit, I think. So, and I'll finish there. So thank you very much for asking me. I'll dip out into my other battles with ICS about funding, closed loops, but I'll stay for a little bit, but I wish you all the very best for the rest of the conference. Thank you.
Thank you, Partha. That was great. Helen, can we hand over to you?
Yes, thank you, Partha, and thank you, Partha, for helping us smash this glass ceiling. We absolutely smashed it with CGM, and I have no doubt that this is going to be even better. And yeah, love a man with an ambitious target. Candice, are you going to share the slides?
I can, absolutely.
So my name's Helen Murphy, and yes, I'm a clinician scientist. I work part-time as a clinician, and the rest of the time as doing the research behind the development of the hybrid closed loop in pregnancy. And I'm just trying to figure out whether I can be so technological as to advance the slides myself. Right, my clicker isn't fully working, Candice. Let me just...
You want to try your keyboard?
Yeah, nothing's happening on my keyboard.
Okay. Try your clicker now.
Aha, something's happening. I don't know if it was you or me.
It was you. Let me take you back.
Sorry, I was trigger
There we
happy.
go. Perfect. You're ready.
So I'm going to go through really in a nutshell why we're here. And we're here because women with type 1 diabetes still continue to have too many babies that are born large for gestational age. And we know those big babies, this is not just a problem for mums who've had to deliver them, but it has consequences for babies who are born preterm, who need expensive neonatal care unit admissions, and in worst case scenarios, suffer birth injuries. And we know that in obstetrics, birth injuries are a real leading cause of medical legal litigation. And of course, we also know that being exposed to too much glucose or above target glucose in utero predisposes these babies to lifelong trajectory of type 2 diabetes and cardiovascular risk factors. So anything we can do to improve maternal glucose during pregnancy will have benefits for both the mum and the baby, both immediately and in the longer term. Candace, I might get you to advance for me because I think it's happening slowly from
Perfect.
down.
I'll do that.
And of course, there are many challenges to managing diabetes in pregnancy, not least the much tighter glucose targets, HbA1cs of less than 6.5% in early pregnancy, less than 6% or 43 millimoles per mole during pregnancy, tighter CGM targets, 3.5 to 7.8, and 70% within that range is no small task. Then we have all of the gestational changes, the physiological changes of pregnancy, and day-to-day variations in how insulin is absorbed, not least the enormous demands on pregnant women to try and get as many glucose levels in target as possible. Next slide. And this is just to give those of you who don't work in pregnancy a real insight into the fact that 70% range in the target range outside pregnancy really only equates to 45% time in the pregnancy range. So it is a much, much tougher ask. Next slide. And as Partha has already alluded to Eleanor and I worked on the concept study in 2017. We showed that there was unequivocal evidence for clinical, but also importantly, health economic benefits using real-time CGM to improve maternal glucose and baby outcomes. And in our initial cost savings, we found that it saved the NHS 9 million, but actually in our real world, more recent data, saving the NHS up to £24 million per year. So this is not just cost effective, it's cost saving. Next slide. And as Partha again said, last year, this was 2022, 95% of all women, 2023, 98% of all women with type 1 diabetes using real-time CGM. So whilst our official target for this may be March 27, I'm totally behind Partha. Let's see if we can get this over the line as quickly as possible, because this will improve obstetric outcomes for mums and neonatal outcomes for babies, and it will save the NHS money. Next slide. And we say that based on the fact that with CGM alone, we saw a 30% reduction in major birth defects and stillbirths and neonatal deaths. So really, the sooner we can do this, the more babies' lives we will save. So I've been working together with Roman Havorka, a bioengineer, really taking the data we had from concept, understanding how these CGM data change through pregnancy, and realizing we have to do more than just give women information about their blood sugars. We have to give them some tools to match the insulin delivery to those sugars. And we've been doing that now with some proof of concept for some time, but more recently on the next slide, with much, much better tools than we've had hitherto. So in our recent study, which was published almost a year ago to the day, it provided unequivocal evidence. Next slide. To show that the sooner we start hybrid closed loop or pregnancy-specific hybrid closed loop in pregnancy, the quicker women benefit. So in the blue bars here, we see standard insulin delivery, insulin pump therapy, or multiple daily injections. And women enter, as I said, around 50% time in range, but they really don't reach the pregnancy glucose targets until the last trimester, telling us that although CGM has really helped, it's not soon enough, it's not fast enough. And what the pregnancy-specific hybrid closed-loop algorithm does is it provides glucose-responsive insulin delivery in the here and now, adjusting insulin every 8 to 12 minutes to very rapidly optimize maternal glucose. Next slide. In addition to the benefits for mums' glucose levels, there were really important quality of life benefits. Young mums being able to stay in paid employment for longer, able to sleep through the night. Substantial reductions in maternal gestational weight gain, 3.7 kilos or 8 pounds, 8 ounces. Lower rates of gestational hypertension, and some of the lowest rates of large for gestational age babies that we've ever seen in a pregnant population of women with type 1, which of course translates into lower levels of neonatal care unit admissions. Next slide. So when we talk now in pregnancy, we use slightly different language. We talk about pregnancy-specific hybrid closed loop to make the point that pregnancy uniquely involves two individuals. So we want to use a system that has a license for use in pregnancy, a system that has a glucose target of at least 5 millimoles per liter, allowing it to target those pregnancy glucose targets, and one with a minimum improvement in the time spent in the pregnancy target range of 5 percentage points. And we do have other systems, of course, and outside of pregnancy, all of the other systems work broadly similarly, equally well, and they're all pretty good at targeting 3.9 to 10. But when it comes to targeting the 3.5 to 7.8, the other systems thus far have failed to deliver any clinically relevant benefits for mums or for babies. Next slide. And what that means in practice across the NHS, where many women enter pregnancy with HbA1cs above target, above 6.5%, it means that if women continued other hybrid closed loop systems, only 1 in 20 would reach the pregnancy targets. Women using those other systems will gain more gestational weight gain, between 3.3 and 5.4 kilos. And their babies have much higher rates of large for gestational age. I mean, clearly that's something no one wants to see. No one who's worked hard to implement CGM and see the improvements we've obtained. We do not want that to go backwards. 69% is where we were in the NHS prior to CGM. Whereas now, with pregnancy-specific hybrid closed loop, we can get 1 in 2 women to those targets very quickly with less gestational weight gain and fewer large birth for gestational age babies. And we know the other systems will get there, but it's just that their algorithms don't do it quickly enough for all of the gestational changes in pregnancy. So using those other systems, women will get to the pregnancy targets in the 3rd trimester. But of course, those other algorithms now need to be refined to be able to refine them to reach the pregnancy targets more efficiently and more quickly. And this, again, is just a summary. So the choice we have is a system that improves maternal glucose, improves neonatal outcomes, or we continue other systems that are associated with more maternal weight gain and more fetal or neonatal weight gain. Next slide. So, of course, we want to support women to make informed choices, exactly as we do around delivery decisions, but we are strongly recommending that women be supported to make that informed choice. And what we're doing is offering CAM-APS before pregnancy where possible, and otherwise swapping to it as soon as possible during pregnancy. Next slide. And the reason for that is because this is the only system with a glucose target low enough for pregnancy. Next slide. And I'm not going to go through all of these. Karen will address the issues around incompatible phones and existing pump warranties. Patient choice, all women want the best for their babies and no woman wants to gain weight. So I think the only real barrier we have now is to get these systems into the hands of patients and clinicians. And the best way to learn about the system is to use it. So I say to my clinical colleagues, have a go. This is going to not just transform the lives of women with type 1 diabetes, improve their babies' outcomes. It's actually going to make your clinical workload so much easier as well. Next slide. And these are just some, if anyone who wants to learn a little bit more about how specifically the algorithm works or how easy it is to use, here are the links. And then I'm going to flip through the last 1 or 2 slides. And this is the final thing from me, is to say diabetes pregnancy teams do one thing: offer pregnancy-specific hybrid closed loop to all pregnant women with type 1 diabetes and make a difference to improving maternal glucose and quite literally saving babies' lives. Thank you.
Thank you, Helen. That was great. Remembering, we will be asking questions or answering questions. Please ask them in the Q&A, and we will come to them later at the end of the presentations. But Karen, can I hand over to you?
Thank you so much, Candice, and good afternoon, everyone. My name is Karen Kennedy, and I'm an Assistant Director within the Diabetes Programme at NHS England. It's an absolute delight to be here with you all. Thank you to Eleanor, joined us briefly, and I'm sure we'll be back, to Partha for setting out the story so far, and to Helen for that amazing clinical evidence that's been presented right before us. And that is truly why we're here today, why we brought the webinar together. And this is the first of many. So I think what I want to do today is to cover 5 things. So I want to give you some context very briefly. I want to talk about the national ambition. We've already touched upon that. I'd like to cover funding, which is very important, and also talk to a couple of those barriers that Helen mentioned earlier, and what we've been doing collectively as a team to overcome those barriers. There's a little bit about data, access and reporting, and hopefully finish with a useful action plan, particularly for colleagues working at system level, about how to get HCL in pregnancy for women with type 1 diabetes mobilised. Next slide, please. So I won't stay long on this. You'll all be well aware of the NICE TA, and it recommended that HCL is made available to the key groups here. And today we're obviously focused on people with type 1 diabetes who are pregnant. Next slide, please. So in terms of a timeline, Partha has been very modest in what's been achieved so far. The TA was published in December, and since then, thanks to the team at NHS England, Sean Crowe, Mark Brodigan, Fiona Earnshaw, Verity Hawkes, and many others, there's been an awful lot of activity happening nationally to mobilise this policy since that TA. It began with a strategy in January, a start of a 5-year programme in April, supplier framework being established, indicative allocations being announced earlier on in the summer, a reimbursement guidance being published then in September. And here we are now with this webinar, and this really is the launch, I would say, of the HCL pregnancy policy area, which is obviously a sub-policy area of the wider HCL piece. There is an important piece that's coming, which is around the baseline from all of the data that's been submitted around the country, and also the reimbursement fixed amount that will be announced imminently as well, which is quite important, and I'll come back to. Next slide, please. So back to that national ambition, and Partha's challenged us to go faster on this. But what we really want to see as soon as possible is that all women with type 1 diabetes are offered hybrid closed loop in pregnancy. We've set out some milestones here. I think we recognise that people are starting in different places, and we also really want to align this with different policy levers. So Helen didn't mention earlier, but should take credit along with Eleanor for engaging with the Maternity Transformation Programme on getting hybrid closed loop into the Saving Babies' Lives Care Bundle next iteration, which is not yet finalised, but certainly in advanced discussion. So that is very positive in terms of that ambition, and we expect that that would align to what you can see here on the slide. So by the end of the 2025 financial year, 60% of women with a minimum ambition of 45, rising up to 95% by the end of the 26 financial year, bringing us to March 27. But as I say, I accept my colleagues' challenge that we want to go further faster on that, absolutely. Next slide, please. So what funding is available to support systems to mobilise HCL in pregnancy? So as I mentioned on the timeline, ICBs have had their main allocation confirmed for this year. You can see an example here on the right. So ICBs received this table through their regional team in July. So that 280,000 example that you see there for any town ICB, that is the maximum amount in reimbursements that an ICS can expect from NHS England in this financial year. And don't forget, this is just the beginning. So this is year 1 of the policy, and there is it is published the expectation that that budget continues to increase subject to annual confirmation each year. We also had published in September reimbursement guidance, and that covers a lot of the detail. So for those of you that are interested in the finance side, I'm sure you will have seen that. If not, it will be shared in the information pack at the end of this. And you can see some of the detail it includes, and it is very clear that there should be a focus in year 1 and year 2 on pregnancy as a key group. So the next crucial bit of information will be when NHS England shares information on the planned reimbursement. And this will allow the ICBs to then do the maths on how many people can be covered within that funding. And as I say, we're very clear that pregnancy is a very key group, and hence why we're launching this webinar, just to make sure that people are very clear on the ambition and the enablers. Next slide, please. So, whilst we are waiting for that reimbursement amount, I think it's very important that you, as system leads in particular, understand your numbers. So it's worth having an understanding of the average number of type 1 diabetes pregnancies within your ICS, if not already. So what does this look like? Well, I can tell you at ICS level, this will look from anywhere between 20 type 1 diabetes pregnancies per year per ICS, up to around 110. So that's quite a big range, isn't it? So some ICSs wouldn't have that many at all. Other ICSs, I guess a bigger geography, more dense population, would have up to about 110 per year. So there are two ways that you can look at these numbers of type 1 diabetes pregnancies. So firstly, you can Google the NPID, National Pregnancy and Diabetes Dashboard, and you'll see a view like this on the screen. And this shows you the numbers at trust level. So note that the red circle there shows the 3-year total. So that's the NPID 2021, 22 and 23, all bumped up together. So the lovely Liverpool Women's Hospital here, if you split that into 3, they have on average 36 type 1 diabetes pregnancies per year. So, you know, certainly if you work in a hospital trust, you want to understand what that looks like, do use the NPID dashboard. I've come across quite a few colleagues that don't know this exists. So we're really keen that people use that. One of the flaws, in all honesty, with the dashboard at the moment is that you can't see at ICS level what the numbers are, but we will be sharing these in an Excel document at the end of the webinar. So if you're an ICS lead, if you work in commissioning or you're a program manager and you're trying to get a sense as to, okay, I have a budget here, how many people, what are the numbers like, then you'll be able to look at that Excel document and understand exactly how many type 1 diabetes pregnancies you have. And sorry, that will be an average figure from the last 2 years of the NPID audit. And then once you know your average number of type 1 diabetes pregnancies each year, you have your funding allocation, and you then receive the reimbursement amount that will follow, you can start to plan better. And this is what we really wanted to do today, is to give you some practical tips and really get you going, both at clinical hospital level, but also in systems, because this is about how we work together to make this happen. Next slide, please. So I'm not going to repeat this because Helen talked about it earlier, but it is relevant to what I want to say on the next slide. So I'm just reaffirming here those 3 criteria that Helen described earlier around what is a pregnancy-specific HCL system. And working at NHS England, I don't give brand names. I won't be speaking of particular suppliers, but when we talk about pregnancy-specific HCL system, and when I talk about it, I mean a system that has those 3 criteria, meets those 3 criteria on the screen. And there's currently only one HCL system that currently meets this criteria. Now, the issue is that I want to talk to you about is that not all insulin pumps are compatible with the pregnancy-specific HCL. So this is the slide earlier where Helen had a box that said warranty. So the issue here is that the existing pump users will still be in a warranty period potentially. And if their pump is not compatible with a pregnancy-specific HCL system, we had a big concern nationally that that would be a barrier to getting women onto a pregnancy-specific HCL system. And so when I started working with Partha and Helen and Eleanor and others on this, we were scratching our heads really thinking, how are we going to be able to drive this forward? And so how can we overcome this barrier of people being in warranty and potentially local systems not wanting to pay twice, which is understandable. Next slide, please. So this is where we come on to another pot of funding. So in the first slide, I'd circled on the right, and now I'm looking at this column here that says allocation for pregnancy pump switches. And the reason this exists is to overcome that barrier about incompatible pumps. It's a £1 million national fund, and it's already been shared out with all ICBs across the country. It gives a contribution to the cost of moving a person onto a compatible pump, recognising that the system costs may have already been accrued. So it's really important to note that this money, for those of you that aren't aware, is already in the ICB's bank. And the reason that I stress that is because it is important to gain a view within your system about how many switches there might be potentially within the ICS, and really work together to try and get those switches to happen. So essentially, we want to make this money work. It's not a huge amount of money, but it has been robustly calculated, and we want to make sure that it isn't sat in the bank at the end of the year. So we really want to help link system leads and clinicians together on this. I think it's worth noting some systems are thinking of using this funding for a local pump pool, which is one idea. Other systems will simply be using it to pay for the individual switches. And currently this is a non-recurrent fund in the reimbursement guidance, but we are considering how we roll this forward, given that we know that pregnancies are unplanned, etc. So you're always going to have an element of women that start on incompatible pumps. Next slide, please. So to help with this, I think it's quite important that systems understand how many pregnant women are on a pump on average. And so again, this is about just understanding the data and actually knowing where to access it. You might find it helpful to estimate that maximum number of pump switches within your ICS as a starting position for a plan. And that will obviously help you to understand then how far that switching fund will go. So nationally, the NPID tells us that about 25% of type 1 diabetes pregnancies are already on a pump. And then when you look at the ICS range, you can see across different ICSs that varies between about 11% up to 36%. So if you think of those numbers I mentioned earlier, that means around 5 to 40 people. So maximum 40 people on a pump in an ICS at any one time. And so I've asked a question of you here, which is what are the baseline levels of pump usage in your in type 1 diabetes pregnancies within your system? And you may not actually know that because the data is not published in the NPID dashboard. But again, just to help you on your way, we will be sharing an Excel sheet at the end of this that shows you how many people, pregnant people, are on pumps on average within your system. So you can start thinking how much of that switching fund you'll need to use. And of course, not every woman will want to switch. This is about choice. But at least you understand what the maximum numbers are and you can really plan to use that funding. Next slide, please. So this is just some simple scenarios that you can see clinicians will come across. And this is just to reiterate how the funding will work. I'm very conscious this is quite complex, quite dry in relation to some of the exciting evidence that Helen presented earlier. But I think the key message here is that, where women are currently on multiple daily injections only, or where they're on multiple daily injections and CGM, what will happen is you'll offer them a pregnancy-specific hybrid closed-loop system. Of course, that's the policy. And at a system level, that will come through the reimbursement pot. And that is really enabled by your data submissions, which I'll talk about later. And then on the other side, if a lady already is using a pump and a CGM and the pump isn't compatible, then the switching fund will help that woman move to a compatible pump that will work with the pregnancy-specific HCL system. So I hope that's clear. You don't need to worry too much about this at this stage. This will all be shared and you'll be able to process and understand it a bit more, but it's just to give you some framing around the funding available. Next slide, please. So Helen did provide a lovely challenge as well with another barrier at the start of this work. And again, this is another one that we were quite concerned about, and that was around the compatibility issue. And that is that the pregnancy-specific HCL system available needs to work with an Android smartphone. And so, of course, From an equity perspective, we know that not every woman has a smartphone, so that's a problem. And we also know that women will have iPhones and wouldn't have access to an Android phone. And so that was another challenge that we've been worried about. And actually, we know now that one pregnancy-specific HCL system is offering all patients that need it a pack with a compatible Android phone. And that is fantastic because it eliminates the barrier of needing to purchase a compatible smartphone. As of today, hot off the press, this option is now available on the NHS supply chain framework, and the URNs are in the process of being sent out. And there's some contact details there for those of you that need it. So huge congratulations to many people that were involved in all of these, addressing all of these barriers. Next slide, please. So on to data, I do get all the exciting topics, but this is really important. So there are two main data reporting requirements. Those of you that work in pregnancy will be very familiar with pregnancy and diabetes audit, but I want to talk to you firstly about a bespoke collection. So it's the National Diabetes Audit Type 1 Diabetes Data Reporting. There's a link there, you can click on it. It has all the information that you need. And for those of you that aren't aware, this is absolutely key. All data has to be reported to support reimbursement. So when you think about that reimbursement pot that I talked about earlier, we absolutely need those data submissions. And thank you to those of you that have been working so hard to submit data so far. The next submission deadline is on the 15th of January. And it says here, very true, your submissions enable us to count new users. We can confirm the eligibility criteria and make sure that your system is reimbursed, which of course will allow you to deliver the best possible care. Not forgetting the importance of the National Pregnancy and Diabetes Audit. Really important that you continue with your submissions. As I'm sure you're aware, the NPID is a continuous submission, but there is an annual deadline each February for the year previous. And that is really important to maintain because this allows us to look at those outcomes. Helen and Eleanor and others will be all over this data, wanting to show those fantastic results that we've seen in CGM. So please do share that data, please do submit it. It will also help us to inform future allocations when we're trying to leverage this policy area. And it'll help us to see and track switches as well onto pregnancy-specific HCL systems. And then I did have the bottom bit in red, but I changed it because I thought it sounded a bit bossy, but complete and accurate data submissions are absolutely vital. So please do help us with that. And then we'll use that data to hopefully help you. Next slide, please. So a bit of a to-do list. Everyone that knows me knows that I really do love a list. And I would say this is quite a system level list. So please don't worry if you're a clinician that you have to pick up all of these actions. You know, they may well be of interest and provide context to you, but thinking at a system level in particular, some of the things that we want to do to enable this good clinical practice. So firstly, ensure that the system signed up to the NHS supply chain framework. Secondly, work with ICB Finance, they are your friends, to identify the switch fund. Most important, it's sat there in the bank, we need to use it. It was transferred in September. But also work with maternity diabetes colleagues to understand how this will be used. There's a good conversation to be had there about how that switching process will work. Thirdly, review the NPID dashboard and the data that's shared in the webinar pack. So remember, the NPID will give you the regional, national and hospital level. There isn't the ICS level in there, but we're going to give you that in the information pack in an Excel document. All numbers are rounded to the nearest 5, but it does at least give you a ballpark figure of where you are on that scale of sort of 40 to 110 pregnancies per year. And as I say, that allows you to start doing your planning. Engage with services. You know, we really want commissioners, programme leads and services to be working together with local maternity and neonatal system colleagues. And that is really, of course, to understand workforce readiness. That is not taken for granted. It is a discussion that needs to be considered locally and worked through. Helen provided some online learning resources on slide 29 that you can look back to. And we've got some fantastic examples coming from Emma and Nina around how to onboard women onto HCL after my presentation. Ensure that services are aware of the reporting requirements, which I've set out earlier. And again, we know there's lots of work going on already on this. So for any of this stuff, you're already well on with it. Please don't feel patronised. It is just to try and get everyone in the same place today. Develop an ICB plan. We all love a good plan. Appreciate there's lots already happening out there, but I think this is definitely worth doing in terms of, well, what would we need to achieve? What are our numbers if we want to hit those ambitions? And if we want to actually surprise and delight Partha and Helen and Eleanor by achieving the ambition early, how many women do we need to get onto HCL to achieve those ambitions? Feedback, any challenges. There's a slide at the end that tells you how we'll be coming out and engaging with you. This is not a once and done. We'll be going to regions, we'll be having subsequent webinars, and we want to understand the feedback and challenges so we can work through them. And sign up to our future site. The details will be shared in the information pack as well, so that you can sign up and pick any resources from there. I think that's it for me.
Thank you. Well done. That was great. So we're going to hand over to Nina now to take us through transitioning to HCL and pregnancy. Thank you, Nina.
Thank you, Karen. That was really interesting. It's so helpful to just see it all mapped out like that. So I'm here today. I'm Nina Willer, diabetes specialist midwife at the Norfolk and Norwich Hospital. We're really pleased and proud that we've got 100% of our patients with type 1 diabetes who are pregnant on hybrid closed loop. So we just thought it might be helpful to just kind of run through the basics of how that happens. Each trust is very different, so a lot of this may not apply, or a lot of the people listening to this is already well and truly up and running. But I just sometimes, when we get all of this new information, it can feel hard to translate that to think, how does that actually look in real life? So that's why I'm here to just talk about what we do at the Norfolk and Norwich, because we're really proud of it. And then after that, Emma will be talking about what she's doing as well, because she's doing a fantastic job there too. I'm going to have a go at changing slides. It's not looking good. Candice, do you mind doing it for me?
No problem.
Thank you. So we really do believe in getting people onto hybrid closed loop as soon as possible from the start of the pregnancy. A lot of these slides will talk about how we do it after the viability is confirmed, but more and more we're trying to do it as quickly as possible, because should the worst happen, this patient have a miscarriage, then they are still an excellent candidate for hybrid closed loop in terms of having it as pre-con care for any future pregnancies, because these are people of childbearing age. So I've broken it down into 4 different parts: the assessment process, transitioning, following up in pregnancy, and then long-term support. So probably the most important bit for me, but that's because I'm a midwife, is that very first phone call with the patient. So people self-refer to say that they're newly pregnant, and we'll call them back and have a really in-depth discussion. And that first phone call just paves the way for the rest of the pregnancy. So we talk obviously about what they're currently doing, an idea of their technology understanding, but more than anything, try and break down any barriers. So a lot of these people haven't come to the main diabetes service for several years. So we're trying to work out kind of why that's happened, so that we can make sure that they have appropriate follow-up for the pregnancy and thereafter. So we do liaise with the doctors and nurses that have been seeing them pre-pregnancy to work out if they have any insight, but most importantly, we just discuss it with the person to see what they find helpful and what they don't, so that we can make sure we can provide tailored care for them. We don't tend to start talking about hybrid closed loop in that first phone call, because there's a lot that we cover. So we get them in for their first appointment, and if it feels appropriate, we might start floating the idea of hybrid closed loop. And some people are coming in completely pump naive, and other people are already quite used to technology. So it's different for different people. And then we confirm viability around 7 weeks with a scan. Thanks, Candice. At this point, we would hope that they will have had a chance to sit down and look at an insulin pump, and it will be kind of working it out in the back of their head. So what I've done is broken it down to 2 different processes. They're very similar, but this first process we're looking at is for people that are already on just an insulin pump that is not compatible with CAM-APS, and people that are on just daily injections, because this is kind of the slightly trickier one and the one that takes a bit longer. So we make sure that we have an MDT approach, so everyone who needs to kind of know about this particular person. So that usually is one of the diabetes consultants, an obstetric consultant, and one of the specialist midwives, all in agreement that this is the right time to proceed with switching to HCL. The trickiest bit, which I actually don't have a huge amount to do with, is the funding process. As you can see there, step 2, our main diabetes service at our hospital have got a very robust pump service, which has been up and running well before my time. I can't take any credit for that. And they are great at ordering the pump and working out getting the funding for the hybrid closed loop app credentials. And so all we do is sometimes we get involved with the prescription process for switching the insulin and deprescribing any strips, and most importantly upgrading the glucose sensor if it's needed. And then really it's the earliest possible HCL start. So what works for us in our trust is we have a rolling booking every 2 weeks. That's a half day every 2 weeks, and it's off-site. It's at a community centre where you can park outside. There's good bus links, and it's made up of a diabetes specialist nurse who kind of sort of supervises the situation from the general side, and a rep from the insulin pump company. And they can do a group start. So what we do is that is already booked in for people that need to switch to pumps who aren't pregnant. And sometimes it's booked for pumps, sometimes it's booked for hybrid closed loop, but it's all the same, all done at the same time. So we sort of piggyback onto that existing booking, which means that we can do it at quite short notice. So in real terms, from the moment we say, let's go ahead with this, the patient's keen, realistically, we're getting most people onto hybrid closed loop within 2 to 4 weeks, closer to 2 weeks. And then we do also have ability to do them, depending on the rep's availability, to just do them ad hoc. So in the past, when we've had big concerns about severe hypoglycemia, we've done it within the week, because it's amazing how helpful the team are when we're really desperate. Could you do the next slide, please, Candice? So this is a much more straightforward way of doing it. If somebody is already on a pump that is compatible with HCL, it's much more straightforward. They're already really familiar with the system, really used to carb counting and things like that. So there's a bit of funding and ordering that goes on in the main diabetes centre, and then the actual HCL start we tend to just do on a video call with the rep. I think this is testament to getting people who are women of childbearing age onto the, if you're not able to get them onto the right HCL for now, just having them on the right pump means that this part of the process is much smoother. But hopefully now what we're finding more and more is that they're just already coming through on HCL because of it being under the pre-con pathway, or people that have had a pregnancy in the last couple of years that have been on HCL and now coming back with their glucose levels tip-top because they've been on it already, and we just carry that on. So follow-up in pregnancy, one of the really tricky things we found in the past with getting people onto an insulin pump is actually these the follow-up appointments with the diabetes specialist nurse, because they're really few and far between. Specialist nurses are very busy at the moment, so actually pregnancy is the perfect time to get someone on an insulin pump or a HCL system, because they're already having their follow-up care with us in antenatal clinic. So it really is just that one-off moment with the DSN to get them on it, and then they don't really have much to do with them then for the rest of the pregnancy. So our pump starts are always on a Tuesday morning, so we get them booked in for our clinic, which is a Thursday, so 2 days later. And then what I tend to do is have a little glance at their data and do a quick data triage the following Monday, and then we will see them in clinic a week after that initial one usually, and then it's just business as usual after that. I will talk about some documents we've recently implemented in just a minute. And then care during admission. So this is the bit that we get a lot of questions about from other trusts. It is a bit tricky. There isn't very specific guidance because people with type 1 diabetes can come in all shapes and sizes, and what brings them into like the labour ward can be for so many different reasons that one flowchart doesn't really cut it. So what we really tend to do is try and empower the patient as much as possible so they've got as much knowledge of what could happen and how to deal with it in that instance. And then we've done intensive training in the trust with the obstetricians, the midwives and the anaesthetists. So everyone's fully on board with the basics. So we're doing what we can, but by empowering the patient, giving them as much information as possible, that seems to be working best. Thanks, Candice. So this is just a document I just wanted to touch on, and we've only started doing this about 3 weeks ago, so it's very, very new, but it is really working. So second trimester refresher on HCL and a third trimester refresher, and it does what it says on the tin. It's basically just like a single piece of A4 paper, and I'll go into a room with the patient and just run through the settings. Do you know how to do these settings? Let's remember the basics, because what we find when people are on HCL is that if we take care of the basics, like remember to pre-bolus, remember to change your cannula, those things automatically boost up that time in range so drastically that if we can just remember those basics constantly, then we just it just has such a positive impact on the patient. We are aware that at 8-9 weeks pregnant, taking on all of that information, if you've never been on an insulin pump before, can be quite scary. So this is a great time to just touch base and just remind them of those things. And that third trimester refresher, obviously my favourite as a midwife, because we just use it as an excuse to do a bit of a birth prep, a bit of an antenatal class, what to bring with you, how to prepare for the labour, and with a little hybrid closed loop segue, just reminding them this is how you do your postnatal settings, and it's just a great time to catch up face to face, and it's being really positively received at the moment. So would recommend definitely doing something like that if you have the chance. Follow-up after pregnancy, it's as simple as we try and see people on hybrid closed loop face-to-face in the unit if we can, if time allows, and if not, selfishly delivered on a weekend. If we can't, then we'll give them a call and stay in touch, and then we just re-refer them back to the General Diabetes Centre. It's really important that we let them know dates of anything that we've ordered so that there's a seamless continuance on, so for example, if we've upgraded their sensor on a 1-year plan, that they can carry that on to continue it so that they can make the most of the HCL for the full 4 years. They are very supportive in our General Diabetes Centre, and our consultants that work with us in our clinic also do work over there. They aim to see a DSN on the phone within about 3 weeks, 2 or 3 weeks, and a consultant within 3 months. And that's it really from me. I'm going to hang around in the Q&A in case anyone's got anything specific they want to ask, but probably most of that will be covered by Emma, because she's going to go into a bit more detail there. So thanks, Emma.
Brilliant. Thanks so much, Nina. It's really fantastic to hear the amazing things that you're doing. We're a slight step behind you, but I'd like to think we're doing an okay job in Derby as well, and I'll share some of our experiences. My name's Emma Wilmot. I'm an Associate Professor at the University of Nottingham and a consultant at University Hospitals of Derby and Burton. I also have type 1 diabetes myself, and I've been through pregnancy twice back in the days of finger pricking before we even had CGM, and I'm absolutely delighted to be in the privileged position of supporting women to have a much, much easier experience during pregnancy. So let me see if I can get my slides moving. Yes, here we go. So when it comes to implementing the technology appraisal, I don't know about you, but as a clinician, it feels like we have a huge mountain to climb. It feels really overwhelming at times. And actually, our team in Derby are fantastic. We saw the TA coming and started having very early discussions about what we can do to support women to get the best outcomes. So we've been thinking about this for a long time. We've had pumps and pizzas evenings, donuts and download sessions, just trying to get the team to a point that they feel more comfortable with hybrid closed loop technology. But obviously, pregnancy and type 1 diabetes is the highest risk time in the life of a woman with type 1 diabetes. And thinking about how as a team can we prioritise those that are pregnant to get the best outcomes. How do we go about delivering starts in what is already a frantically busy antenatal service? And I think the key here really is having all hands on deck. You cannot have one member of your antenatal team leading on this. From the obstetricians to the diabetes consultants, the diabetes nurses, the dietitians, the midwives, everybody needs to be on board with this. We're lucky in Derby, we've seen firsthand the impact it has on women with type 1 diabetes in pregnancy, and we're all big converts. So what are we doing in Derby? Well, we're lucky to have a dedicated preconception clinic, originally set up by Dr. Paru King, now run by Dr. Emma Robinson. And any woman planning pregnancy will be actively offered hybrid closed loop and fast track to get access prior to pregnancy. And of course, across the board, that would be our ideal situation. But we all know the reality is very different. We often see women presenting with unplanned pregnancies. And it's about how we can onboard them to hybrid closed loop very quickly, as early as we can in pregnancy, given the constraints of the services that we're trying to deliver. So as I mentioned, our whole team are very much on board with the benefits of a hybrid closed loop, and we'll start to discuss this as an option. And we talk about it as being an easier way to manage your diabetes and to really hit those targets during your pregnancy. So in Derby, we typically have around 30 to 40 type 1 pregnancies a year, and we are implementing the TA already. Since April, we started 11 people on CAM-APS FX with a 61% uptake, but that's probably an underestimate because some will be still planning to get on access and on to the system. We've had 6 that we've moved from multiple daily injections to hybrid closed loop, and 5 that have come from another pump onto CAM-APS. To do that, we have group starts now booked with the rep every 4 weeks, and we started off with a bit more of a haphazard arrangement, but we're now in the point we've got regular starts. I'm very jealous of Nina with her fortnightly starts, but everybody needs to start somewhere. And of course, we also need one-to-one starts occasionally. So for example, a big challenge, we know that ethnic background can be a barrier to accessing technology, and it's important that you can offer this technology to anybody regardless of their background. So we've taken people who don't speak English, we've managed to get them onto hybrid closed loop with support of interpreters, and actually that's gone really well, and we see the clear benefits from that. So we discussed hybrid closed loop very early on. If the woman's agreeable to moving across, Kathy Kedge, who's our Leeds diabetes specialist nurse in the antenatal service, does a group face-to-face pre-pump education session. And that was because early on we learned that actually expectation setting is really important here, making sure they are aware of what hybrid closed loop is, the pros, the cons, and that this is an informed decision. And Kathy spends time in a group going through the ins and outs and the detail of hybrid closed loop therapy. In the background, we've got our pump admin ordering pump and CGM, which in Derby we do through the diabetes service. We're also addressing the issues around compatible phone and insulin supplies. Prior to starting, they'll need to have done the CAM-APS training. That needs to be completed before the start. And we also offer the Daphne Closed Loop Essentials course. Daphne Closed Loop Essentials is available to all services, whether you're a Daphne service or not. So if you're not aware of this opportunity, if you have a look on Google, you can look on the Daphne website for more information there. So the maximum a woman in our service will wait will be 4 weeks. Ideally, as Nina was saying, you want to get them on as quickly as possible, but the 4 weeks will be the maximum that somebody would need to wait. So if you're not already doing a hybrid closed loop in pregnancy, what I can tell you is it makes life so much easier for the women with diabetes, but also for us as healthcare professionals. Achieving that 70% time in range is so much easier than it is with multiple daily injections. And I've said to my colleague Emma Robinson, my diabetologist that runs the antenatal service alongside me, my goodness, I've just done a clinic and I've not seen anybody with type 1 diabetes with an HbA1c above 48. And this keeps happening. And actually, I had a look at our figures. And in our service so far this year, 73% are achieving a third trimester HbA1c of less than 43. Now, that compares to around a third nationally. And 91% are achieving a third trimester HbA1c of less than 48. This is absolutely transformative. And it's amazing seeing women who typically would have struggled in injections doing so fantastically well. And I want to just bring together everything that we've talked about during this webinar with a clinical case, which really gives you insights into what these systems are capable of. So this is a 29-year-old female who'd had diabetes for the last 5 years. And unfortunately, she'd really struggled to engage with our service. So we hadn't seen much of her at all since diagnosis. And she, like many, presented with an unplanned pregnancy at 10 weeks gestation. Her HbA1c was extremely high at 108 millimoles per mole, and she was on multiple daily injections, but was often not taking her mealtime boluses. She wasn't monitoring her glucose levels at all at the point that she came into her antenatal clinic. So in clinic at the first visit, we got her onto continuous glucose monitoring, and we talked about hybrid closed loop. And suddenly she was understanding the risks involved, and she was very keen to move across to a closed loop. So this is the initial data we had from that first meeting. So 22% time in range, extreme hyperglycemia in what is already a really high risk pregnancy. This is in the background of somebody who hadn't been carbohydrate counting, hadn't been engaging with services. So we had a lot to get up to speed with. We supported her with carbohydrate counting, got her involved in looking at insulin to carb ratios, and got her used to trying to bolus before meals. At 13 weeks, we got her onto CAM-APS, and these are her data from 2 weeks on. Look at that. Absolutely amazing compared to where she come from. And I can tell you now, there's no way that we would have achieved this trying to tweak multiple daily injections. So if we look at the before and after data, and get the other one, we can see that before and after closed loop, literally within a matter of a fortnight, we have transformed her glucose levels. We are giving that baby protection from the hyperglycemia that she started her pregnancy with. Now, don't get me wrong, when you've got somebody like this that's not got to grips with the basics of type 1 diabetes management, they are going to require a lot of intensive support regardless of their therapy. So we're having weekly contact, ongoing intensive education, intensive support, tightening those insulin to carb ratios, tightening the glucose targets as she got more confident with it. And generally we look at starting with that target of 5.5 and then moving it down as we proceed through pregnancy, as long as a woman's confident to do so. For many women, bolusing before rather than after meals is a big challenge. And again, that's often the focus of our conversations in clinic because it makes a huge difference to the glucose levels they can achieve. But for me, this is where the joy is. This woman had a successful delivery at 37 weeks with a healthy baby. She started her journey with an HbA1c of 108 and she left with an HbA1c of 50. Yes, it might not be under that magical number of 43, but she has achieved amazing progress during that time in her pregnancy. So I hope this case gives you confidence to see what, when you take your highest risk patients and take them across to this technology, what you can support them to achieve. So I think that overall, we have a huge opportunity here. Helen and Eleanor have delivered the research to show what this technology is capable of. Our job as clinicians is to deliver it on the ground. I'm lucky to work with a very motivated team in Derby who are already delivering on the TA. And from my personal experience looking after these women, I can tell you it is transforming our outcomes on a level that really is mind-blowing. We need to work to offer every single woman with type 1 diabetes hybrid closed loop therapy, regardless of their background, regardless of their education status, regardless of their ability to count carbs, to support them to get the best outcomes. This is absolutely a watershed moment in the care of type 1 diabetes. And I think this is a time that we should all be really excited to be working in the diabetes antenatal service. Thank you.
Thank you very much. Has Eleanor joined us, or does somebody else want to take this slide and just explain this?
Sorry,
I'm happy.
I will.
Yeah.
Is Eleanor here, or?
I'm happy to step in as the other part of Team Eleanor. And this is really just
Thanks, Helen.
A couple of slides. I think Eleanor is apologising for some technical difficulties, but everything we've said today, all slides will be shared, and we will be repeating some of this information with a few more hands-on tips for how to actually do it in practice at the 13th Diabetes and Pregnancy Conference. I think we've got 1 or 2 slides, Candice. And
Yep.
including hopefully including the QR code. So yes, registrations are now opened. You can register using that code, and I think it's easy to find online. The conference itself will be virtual. It's really cheap to attend, and it's on the 12th of November to tie in with National Diabetes Day. And after, today, obviously, this is one big launch webinar, but we realize people will be at different stages in the journey. So we will be following up exactly as we did with CGM, of having smaller, more regional webinars, giving local teams a chance to have more Q&A. And we're going to plan to do, I think, 8 or 9 of them over the next few months.
Thank you very much,
Karen?
I'm just going to stop sharing. So all our speakers who are here, please come back on your camera. We are going to open some questions. I'm going to field them. We may not get to ask everyone's questions, but we will get back to you. If your question has remained unanswered, we will contact you after the webinar. So it is your opportunity to pop a few more in the post. The first question that I want to put out to is what about type 2? We're talking about type 1, but what about type 2?
Can I take that one? Because Eleanor and I and Karen are working on a large trial, and Nina, of continuous glucose monitoring, CGM, in women with type 2. And, you know, we at the moment, we don't even have data describing the glucose profiles of women with type 2. And we have to have that before we can even start to consider hybrid closed loop. We also need to know much more about the glucose targets in type 2. And we have a real dilemma to know whether some of these newer agents, GLP-1s, even SGLT2s, whether pharmacotherapy is going to be play an important part for women with type 2. So I think it's a much more complex and nuanced picture. And for now, we're concentrating on the type 1, women with type 1. We have not forgotten type 2. And as Karen will say, the most important thing for women with type 2 is going to be around giving them support to plan for pregnancy or to access safe, effective contraception. So the T2Day program will be incentivizing primary care teams to give a little bit of extra care and support to those with early onset type 2. So yeah, we're tackling type 2 from multiple pronged ways in primary care, pre-pregnancy. During pregnancy, we're trying to get some high quality data. If CGM isn't the answer, we'll explore GLP-1s, pharmacotherapy, and or identify whether or not there are women who might benefit from hybrid closed loop.
Thank you, Helen. What about accessing or offering HCL to people who are pregnant but haven't yet done sort of structured education like Daphne or carbohydrating course, which is the normal pathway to accessing pump therapy? What happens then?
Yeah, I'm happy to take that question. So I think the case
Helen.
that I demonstrated there at the end very nicely shows what can be achieved without carbohydrate counting. And I think historically, as healthcare professionals, we've been guilty of putting barriers in the way to accessing technology. The risks in type 1 diabetes in pregnancy are huge with suboptimal glycemic control. So we cannot put these barriers in the way. Every woman should be offered it. And yes, there might be challenges around education levels, around language, around carbohydrate counting, but the joy of working in the antenatal clinic is the ability to give intensive support and input to get that woman to the strongest position possible for managing her diabetes in pregnancy, and hopefully also setting her up for life. We do not stop the hybrid closed loop when somebody finishes their pregnancy, and if they can achieve great outcomes in pregnancy, hopefully they can maintain that for outside of pregnancy. And certainly the NHS England pilot data shows that the people are generally maintaining far better glycemic outcomes than they had in multiple daily injections. So please try to identify any barriers and remove them, because every person, regardless of their background, deserves a chance to have access to this technology.
Thank you. Been a few questions about background retinopathy and the worry about eyes when you rapidly titrate management so quickly. Anybody want to comment on that?
Yeah, I'm happy to comment on that, and it's an excellent question. It's something that is based on theory, really on from textbooks in the past, and it certainly is not something we've experienced over the last 10, 15 years of using hybrid closed loop. And certainly in our trial, we really were very purposely included women with HbA, really, above target. HbA1c is above 86, and we did not see a deterioration in retinopathy. But of course, we'll need big numbers to to understand the nuance of that in more detail. But we don't delay starting hybrid closed loop to get retinal screening. And we do know in consultation with our ophthalmology colleagues, the single most important thing to improve retinal function is to improve maternal glycemia. And actually, anecdotally, what we've seen in our own clinics is women's eye disease improving through pregnancy. So there's no cause for concern, but it is something we will look at closely in the NPID data.
Thank you. So there was a question around, so if somebody's on an HCL and you're not getting that time in range where you need to be, what are the key tips and tricks? Obviously, that's a webinar on its own, but any take-home messages?
I mean, top tip from me, you can get an extra 10% time. If you one missed bolus contributes 5 to 10% time in range. So find the one bolus, the one time they're struggling to bolus, and that's the quickest hack for an extra 10%. Hybrid closed loop will give you 10%, and missed bolus will give you another 10%. And then once women see success, it's easier to build on it.
Yeah, and the other thing I would add is absolutely bolus before rather than after meals. It's amazing how over the years people get into the habit of eat, then give the bolus. Getting it in before is so important. The other thing is let the system do its thing. A lot of women see a high glucose and put in what we call fake carbs, but actually just let the system see what's happening. And another nice thing with CAM-APS is the opportunity to boost. So if somebody's struggling with that postprandial hyperglycemia, there is the option to make the algorithm more aggressive with boost, particularly useful in the third trimester.
Thank you. What about, we spoke about the personal glucose target and using a very tight personal glucose target. Would you jump straight for these tight personal glucose targets in pregnancy, even when HbA1c is high, or would you bring them down slowly?
Absolutely. Every day, the baby's exposed to maternal glucose 24/7. And what we're aiming to do is take the pressure off the fetal pancreas. So the sooner the better. And I think bar 1 or 2 cases where we've started at 5.8 or 6, by the end of the first week, everyone should be on 5.5. There might be a handful of selected cases, but in our experience, it's not many, is it, Nina?
Okay, thank you. There's a few questions about swapping. So if somebody is swapped from their current pump to another pump, so 2 questions. 1, can you use that pump for somebody else? Is that what services are doing? And what happens after the pregnancy? Can people stay on their new system or have choice, or what's happening in real life?
Okay, I mean, I'll just answer the second part, and I'll pass over to Nina, Emma, and Karen. But women always have choice about what they do with their bodies. Number one. In our experience, the postpartum benefits of staying on have been they've been quite incredible. So we've seen women with newborn babies, some of whom Nina has some who are barely bolusing, who are maintaining 70% time in range. So we're not seeing women wanting to stop.
Yeah, it's been a real unexpected, well, for me, it was unexpected surprise to see how little effort people have had to put in the postnatal period to stay in really great target range just by staying on the system. And I thought loads of people would want to come off the system, and actually we've so far not had a single person want to come off the system. And I think just like it can be hard sometimes when people say, how do you kind of convince people to go on it? There's no convincing. We present them the data and we get them to have a look and have a feel of the pump. Much the same when it's about them coming off it afterwards, is we present the data. If you conceive by accident, you're already on this fantastic system. And it's been a bit of a non-issue for us personally. But Emma, I don't know if you've had a slightly different experience.
Yeah, no, I think once people have tried closed loop, they certainly do not want to go back. But I think it's very important to present this as a choice. There are clear benefits for using the system in pregnancy. Have a go if you decide this isn't for you. That's absolutely, there's no judgment there. But within a couple of weeks of using these systems, don't get me wrong, I've got diabetes myself, and when you change from one system to another, it is overwhelming. It is a lot to learn, and it's new. But once you get past that first initial week of the newness, virtually everybody is a convert and said, this is amazing, it's changed my life, and they've got the outcomes to prove it. So yeah, we're the same. The majority of our women would prefer to stay on it in the longer term.
Thank you. And in terms of somebody that you're worried about with the DKA risk, putting them on pump therapy, would you consider some subcut, long-acting insulin, or what are your thoughts?
No, I mean, we very purposely have included some of the younger age women, often with multiple DKAs, often with, other medical and social and sometimes mental health comorbidities. And yes, you have to, counsel them carefully about catheter changes and remind them that they've only got quick-acting insulin. But yeah, some of our best success stories have been in younger age women with above target HbA1cs. They're people who struggle to engage with diabetes services outside of pregnancy. So again, provided the woman can make an informed choice, we would totally go for it. And we really genuinely think those who will benefit most, a little bit like the NHS pilot, may well be those the higher HbA1cs. It's a real opportunity to change their diabetes care, not just for the pregnancy and for the baby, but beyond.
And I think as well, it comes back to the importance of expectation setting before they go on the system. The reality is that everybody on a hybrid closed loop system needs to carry kit with them, so that if that system fails or runs out of insulin or anything happens, that they can safely manage their way through that. And that involves blood glucose kit, ketone kit, backup batteries, backup set change, backup pens, backup needles. So it is quite a lot to carry with them, but as long as they go on to the system, appreciating that that's what's involved in using the system safely, then there's usually not an issue.
There's a question that's come up. Is there anybody you wouldn't recommend should start on a hybrid closed loop system that's got type 1?
No.
No.
Easy answer. The data show that every woman will benefit. And what I would say to that is the choice to start should rest with the woman. It's as Nina said, our job is to give the evidence, and then the woman takes the choice.
Yeah. The only time that you might need to have detailed discussions is if you're in a situation where the individual has a condition that means they can't safely manage. So, for example, severe learning difficulties or something where they might need somebody to support with set changes, with and it's all about. Crucially, it comes down to safety. But in our experience, there's not been anybody yet that's not been suitable.
Can you talk a little bit about birth? So, you've managed successfully during the process, the pregnancy. Now, what happens around the birth process, and any advice? Maybe, I don't know, Nina, this might be for you.
Yeah, this is always the question that we get. Actually, most people in labour, they're not eating very much. They often nil by mouth, particularly our group of patients, because a lot of them are being induced. So actually for being nil by mouth, the HCL works fantastically. And that same goes, there was a question about during times of sickness and hyperemesis. Again, that's when it really comes into its own. Labour and birth is pretty straightforward, I have to say. For caesarean section, we have a few housekeeping bits that we go over in that third trimester, and that's things like remember to take a spare, because we advise for them to stay on their HCL for the caesarean section always, unless they're not well enough to self-manage themselves with the help of their birthing partner. So we recommend they take a spare sensor, spare cannula, spare cartridge, spare line, everything in a little tub, and if anything goes awry, then when they get into recovery, they can put a new cannula in straight away. Actually, the amount of time, the frequency that you need to measure someone's glucose levels when they're in caesarean section is really not very often, but funnily enough, when they're on hybrid closed loop, the anaesthetist is usually looking at it about every 3 minutes because they really like to see those numbers. So essentially that, again, was something we thought was going to be a big issue. Turns out it's quite a non-issue. We personally recommend that people have a Teflon cannula as opposed to a steel cannula. If it's an elective procedure and we've got the time, then I recommend that they would put a Teflon cannula and a sensor probably in the same arm so that the anaesthetist can use the other arm for blood pressure monitoring, and to avoid any area where there's going to be any of the sterile wash, because particularly in the buttocks and that lower bit of the lower abdomen, just because there's a higher chance of having a pressure sore. Otherwise, it works really smoothly, and being the control freak that us diabetes specialist midwives are, we're straight into recovery as quickly as possible to change over to their postnatal settings. In reality, it doesn't have to be that quick because they're not usually eating for a while. But yeah, that's part of what that third trimester refresher does for us, is just kind of really update the patient.
And if clinicians want to sort of learn more, there are obviously some very experienced people who are using the system, but if you're just starting, where can people go to learn more about the system itself, how, these features like boost and ease that you've talked about, and then the different processes during the trimesters and birth and postnatally?
Well, Candice, there's the Incident Safety Week webinars that you've hosted. And then, of course, on the CamDiab website, there's links. So I think, yes, there's, some short bites, some 4 or 5 minute videos, and then there's some longer, more detailed materials. But honestly, myself, Eleanor, Emma, Nina, we're all happy to be contacted. This is our favorite topic. We will, we all started out somewhere, and we're more than happy to support other teams on this journey.
And I think as well, we also had the diabetes technology guide for diabetes technologies in pregnancy, and we are planning to update that for hybrid closed loop because we're aware that there's a great need out there.
Thank you. Thank you. That's great. And just one more question about postnatally. We're aiming for sort of 5.5 and 5 and 4.5 overnight in pregnancy. What do you put the target at postnatally?
Generally 6. I mean, either 5.8 or 6, and maybe if a woman's breastfeeding, if she is having hypos, you know, you might raise it a little bit, 6.5 for a few weeks. But by and large, the average glucose target for the first 6 months postnatal in our study has been 6.
Thank you very much. There are a few questions in the chat about, you know, what pumps are compatible, and just confirming the phone availability. Is the phone, you know, that's available as part of the funding, is that available with both pump options?
That might be one for you, Karen. I tried answering it in the chat and then I was frightened to say something wrong.
Okay. So sorry, Candice, the question was about the phone compatibility.
And no, about the pumps that are compatible, and is there a phone that comes with both pump supplies? So it's sort of a choice of which system. Obviously the hybrid algorithm is the same, but the pumps and the phones, is the offer similar no matter what pump they use?
So in terms of which pump, I think Helen kind of covers that within her presentation, and well worth watching that back. And then we presented an offer that we're aware of from one system supplier that is compatible with the pump that Helen referred to. So sorry to be a bit cryptic, but clearly, you know, our interest here is in outcomes. And so it might be that attendees have a look through the slides, and I think it should become clear once they look at that, we're just somewhat limited into what extent we can verbalise manufacturer names, as I'm sure you'll understand.
Perfect. No, that's absolutely perfect. Thank you very much. I'm just going to share my screen again and take us through some last minute housekeeping. You will notice that there's a little feedback that pops up. Please give us some feedback. We'd love to hear some more from you. When you leave the webinar, there will be a survey on your browser. Please do spend a minute filling that in for us. That feedback really helps shape how we go forward and deliver webinars and potentially other options for you as part of this HCL in pregnancy rollout. I can confirm that a certificate of attendance and a copy of the slides will be emailed out to you. Please look out for that email. It will be sent within the next week. If you do not receive it, please reach out to us here at CDEP at info@cdep.org.uk. We will also be loading the slides and the recording on the CDEP website under webinars, so people will have an opportunity to watch it back. We are fully aware that people who have registered may be called away halfway through, so you know, you can watch the rest or share it with the team as part of that. So please do feel free to look at that, but those information will also be in the email that we send to you. We'd like to thank NHS England for all their help in spearheading this webinar, driving forward, and for the amazing people who have really sort of moved heaven and earth to bring this to reality. So, you know, from Emma and Nina, Helen and Eleanor, Partha, Karen and Verity, a big thank you from all of us who are watching. You know, your work is inspiring. You know, this is going to make a big difference to people and their babies with type 1 diabetes. So I think that's just amazing. There are some contact details for you if you have any contact, wanted to follow NHS England and keep up to date with what is happening. So thank you very much for everyone attending this awesome webinar. Really appreciate everyone's time. The questions we haven't got to, we will respond to outside the webinar. Apologies for that, but there were just so many. And please do watch the space for other opportunities that are coming along with hybrid closed loop in your area, just to help support you. But please do reach out to us at CDEP or to the team if you have any immediate questions. We'd be happy to help you. So thank you very much for everyone. Don't forget to complete the survey. And other than that, I'm just going to bring this to close and thank you, speakers. You did great. So awesome work as usual. So thank you very much.